Chapter 12, Bipolar Disorders Lecture. Welcome to Chapter 12, Bipolar Disorders. In this lecture, we will discuss the different types of bipolar disorders, why bipolar disorder can be difficult to diagnose, symptoms of mania, treatment options, medications and their side effects, important nursing interventions, and key teaching points for patients taking mood stabilizers. Bipolar disorder is a mood disorder characterized by dramatic mood swings that range from profound depression to extreme euphoria, known as mania. Between these episodes, some individuals may experience periods of normal mood and functioning. These mood shifts are much more intense than normal, ups and downs, and significantly affect occupational, social, and personal functioning. There are several important terms to understand. Mania is a state of elevated, expansive, or irritable mood accompanied by increased energy and activity. Hypomania is a milder form of mania that does not cause severe impairment or require hospitalization. Cyclothymic disorder refers to a chronic mood disturbance lasting at least 2 years that involves numerous periods of hypomania and mild depressive symptoms that do not meet full criteria for major depression. There are 3 main types of bipolar disorders. Bipolar I disorder includes at least one full manic episode and often includes major depressive episodes. This is the classic form most people picture when they think of bipolar disorder. For example, a patient may go days without sleep, spend excessive amounts of money impulsively, believe they have special powers, and require hospitalization due to unsafe behavior. Bipolar II disorder includes recurrent major depressive episodes along with episodes of hypomania, but the individual has never experienced a full manic episode. For example, a patient may have severe depressive episodes and occasional periods of increased productivity, reduced need for sleep, and elevated mood, but never becomes psychotic or severely impaired. Cyclothymic disorder involves chronic mood fluctuations for at least 2 years with repeated periods of hypomanic symptoms and mild depressive symptoms that are less severe than those seen in bipolar I or II. The exact cause of bipolar disorder is not fully understood, but it is believed to involve altered levels of neurotransmitters such as serotonin, dopamine, and norepinephrine. Increased levels are associated with manic episodes, while decreased levels are associated with depressive episodes. Genetics also play a strong role, as shown in twin studies. Environmental stressors such as trauma, major life events, or sleep disruption can trigger episodes in susceptible individuals. Certain medical conditions and medications may also precipitate manic episodes. Approximately 4.4% of the American population will experience bipolar disorder during their lifetime. It affects males and females at approximately the same rate. The average age of onset is around 25 years old. After the first episode, there is a high risk of recurrence. Some individuals may go years between episodes, while others experience frequent cycling. Bipolar disorder is also the most common cause of postpartum psychosis. Bipolar disorder can be difficult to diagnose because patients often seek treatment during depressive episodes rather than manic ones. Hypomania may be overlooked because the individual may feel productive and successful during that time. Symptoms can also overlap with substance abuse, ADHD, or other psychiatric disorders, leading to misdiagnosis. Manic symptoms include a very elevated or irritable mood, hyperactivity, increased energy, racing thoughts, and flight of ideas. Patients may talk excessively and rapidly. They often have little need for sleep and may feel rested after only 3 hours. They may demonstrate inflated self-esteem or grandiosity, believing they have special talents or abilities. They are easily distracted and may have poor temper control. Reckless behaviors are common and may include drinking, drug use, binge eating, promiscuity, spending sprees, and other impulsive decisions. For example, a patient may max out multiple credit cards in a single weekend or quit their job impulsively believing they are destined for fame or wealth. In the early stages of mania, the individual may appear highly productive, engaging, and energetic. However, as mania progresses, behavior becomes frenzied and disorganized, leading to impaired judgment and potentially dangerous actions. The manic phase may last from days to months and may include psychotic features. The depressive phase of bipolar disorder resembles major depressive disorder. The primary treatment for bipolar disorder is mood-stabilizing medication. Psychotherapy is also important for support, improving coping skills, and promoting medication compliance. Additional medications, such as antipsychotics or anti-anxiety medications, may be prescribed depending on symptoms. Common mood stabilizers include lithium, valproic acid, carbamazepine, and lamotrigine. Lithium requires close monitoring with regular blood tests. Therapeutic blood levels for most stable patients range from 0.5 to 1.2 milliequivalents per liter. In acute mania, levels may range from 1.0 to 1.5 milliequivalents per liter. Lithium toxicity can occur if blood levels become too high. This may happen with dehydration, excessive sweating, or chronic diarrhea. Early warning signs of toxicity include nausea, vomiting, and sedation. More severe signs include tremors, confusion, seizures, coma, and even death. Nurses must carefully monitor lithium levels and assess for side effects. Nursing interventions for patients experiencing mania require patience and consistency. Nurses should provide clear and firm limits, promote honest and therapeutic communication, and maintain a structured environment. Ensuring patient safety is a top priority, especially if impulsive or reckless behavior is present. Encourage adequate nutrition because manic patients may forget to eat. Encourage appropriate activity, but redirect excessive or unsafe behavior. Monitor lithium levels and observe for signs of toxicity or other medication side effects. 2 important teaching points for patients taking mood stabilizers are that they should never stop taking the medication abruptly, even if they feel better, and they must attend regular blood tests to monitor therapeutic levels. Patients taking lithium should maintain adequate hydration and report symptoms such as nausea, tremors, or confusion immediately. Educating family members about side effects and early warning signs of relapse can improve long-term outcomes and compliance. In summary, bipolar I disorder includes full manic episodes. Bipolar II disorder includes hypomania and major depression. Cyclothymic disorder involves chronic milder mood swings lasting at least 2 years. Lithium levels must be monitored carefully, with therapeutic levels between 0.5 and 1.2 milliequivalents per liter in stable patients. Early signs of lithium toxicity include nausea, vomiting, and sedation, while severe toxicity includes tremors and confusion. Early recognition, medication compliance, therapeutic communication, and safety-focused nursing care are essential in managing bipolar disorder effectively. End of lecture.